next case for you. This is a classic case.
Okay. It's a frontal chest radiograph, skeletal mature patient. Okay, I can see that is a bilateral symmetrical pattern of. Firstly, I can see that there is a peripherally inserted central line
Yes,
in
this is
the
a
left
clue.
side.
Yes.
Okay, it's seen in the left line, so I assume it's there is a left superior vena cava, or it's internal thoracic vein or previous venous access. So these patients have a bilateral, mainly upper tramline changes and suggestive of bronchiectasis.
Okay. Good. Good. So you are thinking in. If I told you young patient,
Okay, it's not cystic fibrosis.
it's a classic cystic fibrosis.
Yes. So why I was faking? I was heading to the diagnosis.
By the way, in the exam, don't expect all examiners will be kind. Many of them, are you sure? Are you sure? Are you sure? Okay.
Uh-huh. Okay.
This is an example. Another example will be so so aggressive. Okay, so don't expect all to be kind. You have to be self-confident. Okay, it's cystic fibrosis. Okay, proceed with the CT of the same patient.
Okay, upper and mid lung zone varicoid bronchiectatic lung changes. Also, there is some areas of central lobular nodules and the tree input. Okay, there's no loss in the lung volume. I would like to exclude complications such as pneumothorax, pulmonary hypertension, or allergic bronchopulmonary aspergillosis.
Good.
So it's a case of uncomplicated cystic fibrosis with bronchiectatic lung changes.
Okay, okay. The next case for you too.
Okay, frontal chest radiograph, splitting mature patients. There is left-sided peripherally inserted, right? Okay.
Yes.
Central line. Okay. Okay.
It's
There's bilateral.
is it? I'm sorry. Is it peripherally inserted?
No, it's central line.
Usually, this pattern is tunneled under the skin. Maybe with a classic portacase or permacase, or maybe not. Okay, this is usually tunneled under the skin. And if you see this pattern, you think in what
Cystic
are the
fibrosis.
yes, cystic fibrosis in young age with this pattern of bronchiectasis. Okay, in
Mhm.
old age,
Okay, chemotherapy.
yes, yes, chemotherapy. Okay, the same here was added
Bronchioceal.
bronchocele. Okay, what's the indication of mediastinal window? Why you want to see mediastinal window?
Mediastinal window. So if there is allergic pulmonary mucoid infection or
Okay, anything in the abdomen?
complications. Yes, if there is portal hypertension or replacement of the pancreas, lipomatous replacement
Very good, very
of
good,
the
very good.
pancreas.
You have to mention this to complete your case. Okay. Thank you, Yabos. Thank you. It was cystic pattern. Now we talk about bronchiectasis. The predominant pattern here is cystic. Okay, cystic. The next candidate, it's easy. I think 3 easy cases. Who will be next?
Yes, I'm candidate 8.
Okay, you are lucky. Okay, proceed, Yabos.
So this is a frontal chest radiograph of a skeletally mature patient. I can see there is reduced lung volume on the right side.
Okay.
In the right lower lung zone, there is bronchiectatic changes. I can see dilated varicoid bronchi. So isolated bronchiectatic changes in an adult patient usually is post-infectious. So I would like to ask for the history of the patient.
Okay.
And Yes. So the CT scan confirms the cystic or varicoid bronchiectatic changes affecting the right lower lung zone.
Yes.
Um,
No signs of active infection, no tree in blood, no fluid layering, or no pneumothorax. Okay. The second, this is post-infectious bronchiectasis, which predominantly affecting the lower lobe. In chronicity, it has some sort of volume loss. Okay. In chest X-ray, it has also some, let's say, lower lobar affection.
Okay.
What about CT?
So this bronchiectatic changes is limited to the right middle lobe.
Yes.
Uh, there is no evidence of active infection or clean blood appearance.
Okay.
Um,
Maybe
so
some is here. Okay.
yeah, there is a patch of ground glass opacity affecting the right lower lobe, the mediobasal segment.
Yes.
Uh,
Okay. About this pattern.
yes, it's also bronchiectatic changes.
Yes.
Patient is suspicious for mycobacterium
Excellent.
intracellular or Lady Windermere
Yes.
syndrome.
Yes. Yes. Okay. If the lower lobe is affected on one side or both sides, this post-infectious. If the middle lobe or lingula, this specific for Mycobacterium avium intercellular or Lady Windermere. This is localized type of bronchitis. Excellent, yeah, boss. Okay, the last case is also easy for you.
Okay, so this is a frontal chest radiograph. Um, first of all, there is dextrocardia. There are also bronchiectatic changes affecting both lower lung zones.
Yes.
This seems like a young patient, and there is also signs of volume loss. So I'm thinking of Cartagner syndrome or
Yes.
primary
Yes.
ciliary dyskinesia.
Yes. Okay.
Uh,
Dextrocardia and this
yes, and situs,
situs
the
inversus. Okay.
situs.
This situs inversus, and you mentioned the rest of Cartagner syndrome. This is very easy to come in the exam, but just I want to enlist all possible scenarios of a cystic lung that mimics a bronchiectasis. If you think in this cystic pattern to be a bronchiectasis, look for porta cas or central line, tunneled line in a relative young age. Think of cystic fibrosis if upper lobar predominance. If lower lobar predominance, think of post-infectious. If it's specific to the middle lobe, think of Lady Windermere. And if lower lobar associated with situs inversus, whether bronchiectasis alone or bronchiectasis with mucocele, finger glove, or something like this, Cartagner syndrome. Excellent, yeah, boss. Thank you. Okay, I think this pattern also. The next candidate.
Good evening, sir.
Good evening, yeah, boss. Good evening. Okay, shortness of breath.
Yes, sir. So I'm provided with frontal chest radiograph of adult patient who is presented with shortness of breath. Uh, Looking at the radiograph, I noticed that there are multiple, um, yeah, bilateral reticular. I noticed that there are prominent bilateral reticular opacities
Good.
along with cystic lucencies noted predominantly in the bilateral upper and mid lung, with relative sparing of the lower lung and the bilateral costophrenic angle. Apart from that, I do not notice any other nodular opacities in the bilateral lung. Bilateral costophrenic angles are sharp. I do not
Yes.
see any
Yes.
pneumothorax or
Good.
any pneumomyastina.
Good.
So in this patient who is presented with shortness of breath with cystic lucencies, uh, I am thinking of cystic lung disease. Could be Langerhans cells histiocytosis, and if it so yeah, and since this is not a female patient, I'm not thinking about lymphangiomyomatosis.
Good.
Apart from that, if it is a immuno, yeah,
Yes.
So if it is immunodeficient patient, I would also have thought about lymphocytic interstitial pneumonia, but I'm not keeping it in my top differential.
Lymphocytic interstitial pneumonia.
Yeah, but I'm keeping
Okay.
it in low in
Most
my.
autoimmune pathology, not immune compromised, I think. Okay.
Yeah. So
Okay.
yeah,
Okay.
so
What specific history do you want to ask?
I would like to know if the patient is smoker.
Yes, this is on top of the list. What if female?
Yeah, if it is a female patient, I would think about lymphangiomyomatosis
And
and
also ask about history of smoking.
yeah.
Okay.
Yes.
Langerhans in a smoker, male or female. Okay. Okay. CT scan, yeah, boss.
So I'm provided with axial CT thorax image, lung window images of this patient. Looking at the images, this confirm my finding of presence of multiple bizarre shaped cystic
Yes.
lucencies, predominantly in the upper and the mid lung. I also noticed there are few nodular opacities noted in the bilateral lung. So with this
The
finding,
nodules usually sparing the pleural surface. Okay, it's just to mention. Okay.
yes, sir. So considering these findings, this confirm my finding of Langerhans histiocytosis.
Good, yeah,
And
boss. My friends, when you suspect, when you suspect a reticular pattern, comment on the lung volume. Comment on the lung volume. Preserve the lung volume, think again. Or try to zoom any nodules, any shaggy border, any cystic changes, because cystic pattern is a common mimicker for reticular pattern, for fibrotic pattern. The first case of this cystic pattern is Langerhans. Okay. The second case for you too, boss.
yes,
X-ray
sir.
was very easy, so I never comment on this.
Sir.
Just describe.
Yeah, so I'm provided with axial CT lung window images of this patient. In this, I noticed that there are multiple cystic lucencies noted in the bilateral lungs. Apart from that, I also noticed that there is presence of pneumothorax on the left side. Uh,
With chest
okay, so
tube. With chest tube is seen.
yeah, with chest tube seen. These
Please
are
don't
described.
forget lines and tubes. Don't forget lines and tube, because maybe this chest tube malpositioned in the subcutaneous tissue. You have to comment on this one.
Yes, sir. And also these are bizarre shape lucencies. So I'm thinking much in terms of Langerhans cell histiocytosis. Apart from that, I also noticed that there is area of basal consolidation on the left side, basal collapse consolidation
Yes,
on the left.
yes. Very good, Yapos. Very good, very good. Okay, the next case, you can continue. This is easy case and in the same category. How to describe?
Okay, I'm provided with frontal chest radiograph of an adult female patient. In this, I noticed that there are multiple reticular opacities in both lung, and also multiple cystic lucencies uh, distributed in, uh, diffusely distributed in both lungs. Since this is a female patient,
And
multiple
the lung
cystic
volume is
lung volumes are preserved. Apart from that, I also noticed that there is some blunting of right costophrenic angle and the left costophrenic angle. This could be because of uh, overlying soft tissue density, but I would like to confirm this on CT images. So
good.
so considering these findings, I'm thinking, she is a female patient. I'm thinking about lymphangioma lymphangiomyomatosis. I would
Yes.
uh, I
What
would
about this? What about this?
uh, this tube probably has been placed to, maybe the patient has scalus pleural effusion.
Yes. Ask for
Yeah.
a
So yeah.
history
So if the
or
patient had a Yeah,
yes.
so if the patient had associated callus effusion, probably this tube was placed to drain that callus effusion. And I would like to confirm my finding on CT images.
Good. Let's finalize with
I'm provided with axial CT, thorax, and lung window images of this patient. In this, I note that there are multiple well-defined cystic lucencies seen in the both lungs. Apart from that, there is also left-sided pneumothorax.
you mentioned the
Also,
cyst. The cyst now has thin wall, regular shape, and involving
both lungs, also the bases.
yes, the lung
Also,
bases, costophrenic angles are also involved. Just to differentiate it from the first case.
yes.
Then you comment on the complication for which they did this chest tube or pectoral catheter. There is the residual pneumothorax. Okay, any indication for mediastinal window?
Sir, to see
No need, I think, right?
yes, sir. Yes, sir. Yes, sir.
Are you sure no need?
I can see
No need. Huh?
yes, sir. But yes, I can see the changes in the kidney. I can see multiple bilateral angiomyolipomas in the kidney of
Yes.
multiple fat-containing lesions, angiomyolipomas, and so this is a tuberous sclerosis patient. And I would also like to see the brain images to see.
Good. So now you see a mediastinal window or soft tissue window can complete the case. So you have to know what is rest. As in cystic fibrosis, look for the liver, look for the pancreas, fatty changes, portal hypertension, and so on. And here, angiomyolipomas because of the tuberous sclerosis. Then you can recommend brain CT or MRI. Very good,
Yes.
Yabos. So the
Thank
first two cases of reticular pattern that mimics the fibrosis, but lung volume is preserved is Langerhans cystosis and lymphangiomatosis. But on zooming these images, you can see minute cystic changes. So the predominant pattern will be cystic, not reticular. Okay. If X-ray, this is another case of LAM. LAM, to differentiate it from histiocytosis, the distribution and the size of the cyst. In Langerhans, usually it preserves the lung base and costophrenic angles, but in LAM, it is affected till the lung bases. Here, the cysts are thin-walled, uniform, but in lymphangio, thick-walled, bizarre shape with nodules. Because this
Yes.
condition is starting as nodules, then the nodules cavitating. Okay. Thank you, ya boss. Thank you. Okay. The next one. Come, Dr. Ahmed. You waited so much.
I see. Yeah, I see. Candidate 10 is there. There is candidate 11 also.
Okay.
خلاص, candidate, don't be shy. Come.
Okay, I'm here.
Okay. Okay.
Okay.
Shortness of breath. Or I will not tell you the history. You suggest the history. Just comment on the film and suggest the history.
Okay. I'm presented with a frontal chest radiograph for an adult patient. I can see that there is fine reticulonodular shadowing in both lungs, mainly at the mid and upper lung zone, with the faint airspace hazy opacity seen surrounding them. I can see also small cystic lucencies intervening between them. I cannot see any hilar, or maybe the left hilum is mildly enlarged. There is no pneumothorax, no visible masses, costophrenic angles, they are clear. The lung volume is preserved, and no obvious bony pathology. I will correlate this finding with the clinical setting of this patient, and will compare it with any previous images of the patient. If this patient is coming in an acute onset with fever, shortness of breath, and he is immune compromised, I will think of infection on top of my differential diagnosis, such as pneumocystis jirovecii pneumonia. Yes, mainly this infection, but I would like to.
Okay, other types less likely. Very good, very good, very good.
Yeah.
Because here, if you notice, my friend, the faint opacification involving mainly the central area. The peripheral chest is preserved with these subtle opacities, okay, and some reticulation and minute cyst within. This is classic for pneumocystis pneumonia. This is another case, but consider it the CT of the same case. Can you comment, boss?
Okay, so this is just CT scan with contrast for an adult patient, showing that there is ground glass opacification with interlobular septal thickening and tiny cystic lucences, mainly seen in both mid and upper in the upper lung lobes and the apical segments of the lower lung lobes, mainly in central distribution with relative peripheral sparing. There is no pneumothorax, and I will continue to the rest of the image to confirm that there is no pleural effusion. There is mild right hilar, small يعني mediastinal lymph nodes or hilar lymph nodes. Yes, and again, I will يعني say the same thing. You know, if he is coming with acute illness, the pneumocystis jirovecii will be on top of my differential diagnosis.
The last case for you too.
Okay, chest CT scan for an adult patient, showing that there are multiple different size and different size of cystic lesions diffusely scattered in both lungs, with hazy background ground glass opacification of both lungs with the relative mosaic attenuation of the lung.
The pattern is stationary since many years.
Stationary since many years. Okay. Can I see the down to the last image?
Okay. What is your differential? Just to give differential, no problem.
Post-infectious pneumatoceles.
What else?
If it is stationary, I was going to say.
Any specific history do you want to ask?
Okay, smoking history, because of desquamative interstitial pneumonia associated with that.
Very good, very good.
Yes.
What else?
Also, if it will be slightly remote, I think, the lymphocytic interstitial pneumonia, if the patient is having a Sjögren complex or so, to suggest lymphocytic interstitial pneumonia, because it has a lower lobe predominance. Yes.
Okay, I think this was a case.
Yeah, left. Okay.
Okay. You can ask about history of autoimmune etiology. Okay.
But I thought it was lower predominance. Okay.
No problem. No problem. Okay. But just you give a differential.
Yes.
As you said, smoking or autoimmune, less likely the other types we mentioned. These are the common cystic pattern we may encounter in the exam setting. Langerhans cell histiocytosis and LAM and pneumocystis pneumonia, the least type lymphocytic interstitial pneumonia or desquamate. Yes. Very good, yeah, boss. Very good. Thank you. Okay. I think we covered now some nodular pattern or micronodular pattern, cystic pattern that may mimic reticular pattern. Now some other lesions also for a differential. Who is the next candidate? 11?
Yes, I am candidate number 11.
How are you, boss?
I'm fine, thank you.
Okay, proceed.
Yes, I have been presented with the frontal chest radiograph on an adult patient. I can see that there is implanted left-sided pacemaker, single chamber.
Good.
I will trace the lead to see if there is any fracture or malposition. I can see that it is in the satisfactory position because it's seen in the area of the left ventricle. Also, I note
Okay,
yes.
just over the heart, because
Over the heart, yes,
where
it
it
is
is located,
projectionary.
in the left or in the right?
It is on the left side.
In
of
the
heart.
right, in the right. Okay, okay, okay.
Okay, no problem.
No problem. What else in the film?
Okay. Yes, I can see that there are multiple variable size lesions seen in both lung fields. I can see one of them appear cavitated with air fluid level seen at the left mid lung zone.
Very good.
I can see that there is triangular shape seen in the right lower lung zone. I cannot appreciate the right hemidiaphragm, which could represent lower lobe collapse, right lower
Good.
lobe collapse.
Good.
Yes.
Okay.
So my interpretation for this case is multiple bilateral lung masses, one of them appear cavitating. My differential diagnosis for this, it could be due to metastatic. I will correlate if there is any surgical eclipse within this image. Also, I will see the record of this patient. Second of all, I want to see if there is any history of septic emboli or previous pulmonary embolism. It could be one of the differential diagnoses. Also, I will check if the patient has any sinusitis or glomerulonephritis. I was thinking about granulomatosis with biliangitis, previously known as vaginal.
excellent approach يا boss. يعني ما شاء الله. Okay, okay.
Thank you.
Also, you ask about if IV drug abuser and so on. Okay.
Yes.
The next, I think this was cavitating lung metastasis. What are the common tumors that cause cavitating lung metastasis?
Yes. Cavitating lung, it's like a squamous cell carcinoma of the head and neck. And also, it could be due to osteosarcoma or testicular tumors.
Good, yeah, boss. Okay, another case for you too.
Yes, I have been presented with frontal chest radiograph on an adult patient. The main abnormality, I can see at least two rounded lesion, variable size, seen in the right lung, or maybe more than that.
Yes.
It could be due to projectionary. The largest one of them appear. I don't know if it is cavitating or not. However, there is no calcification seen within this mass lesion. Yes, it's look like central cavitation inside. Yes, and also there is no cavitation within this mass lesion. I cannot appreciate any lymphadenopathy. The left lung fields appear clear. There is no pleural effusion and no cardiomegaly with no retrocardiac mass lesions. Also, I cannot appreciate any bony destruction beneath these lesions. I cannot appreciate any surgical eclipse within this image. So my differential diagnosis, my interpretation, this is a case of multiple right lung lesion. One of them appear cavitating. I will correlate with the patient age and presenting feature. If the patient is known case of malignancy, my top differential will be those of metastasis. Other than that, if the patient is presented with acute chest pain, I will thinking about pulmonary embolism and septic emboli.
So the main differential may be related to neoplastic or infectious. Anything in the radiograph that may guide you to one of these differential?
Between neoplastic or metastasis?
Or infection?
Or infection. Yes, I want to see if there is any surgical eclipse or history of a previous surgery. I can see that there is left breast shadow. It's small, but I cannot. It is absent in the right side. So it could be due to.
This is a male patient.
It could be male patient. Yes, it could be male patient. Yes, I also noticed that it is asymmetrical. So I thought it could be a small breast and absent on the right side. However,
this is a breast shadow or something else.
Yes, I can see that there is like hypo or lytic area seen within it. It could be due to skin folds or something, or skin thickening.
There is air. right? You see
Yes,
this radiolucency, air with overlying soft tissue thickening. You think in
abscess collection.
yes, yes, abscess. Okay, so good. Okay, proceed to CT scan and comment.
Yes, this is axial image CT scan with IV contrast for an adult patient. I can see that there is multiple cavitary lesion on the right side. Also, I can notice that there is multiple nodules seen in the right lower lung lobe, taking the feature of tree and bud appearance with atelectasis and seen in the farmost lower lobe. Also, I noticed that there is a collection with air foci seen in the subcutaneous area of the left chest wall related to the patient known abscess collection. So it could be due to, yes, I can see that also there is air fluid level seen, and yes, there is air fluid level. Okay.
So in summary,
in summary, I think this is a case of infectious rather than neoplastic process. Due to presence of abscess collection and also multiple nodules in the and maybe a pleural effusion on the right side. On the top of my differential diagnosis, because of this appearance and the tree bud pattern, I was thinking about TB infection. Although
okay.
typically TB could be in the upper lobes.
Yeah, just active infection, active endobronchial infection. It was a case of septic emboli, I think, in intravenous drug abuser. But clue here to be detected from X-ray. It's cavitary lung lesions. Cavitary lung lesions, as you said, may be neoplastic, may be infectious, maybe Wagner, okay, granulomatous. But here there is a sign of infection. Okay, I'd like to take further history about if the patient is a drug abuser or no. I think this one is favoring the heroin. Okay, thank you, ya boss. Thank you.
Thank you very much.
Okay, welcome. Yes, yes, it's infectious. Okay, another one in the category. I think it's easy. Candidate any 12 or back to one?
Back to one. So
Okay,
this is
boss.
a frontal radiograph. I see that there is a mass in the actually two masses in the right lower zone, and there is also a big mass in the left upper zone. The lung volume is preserved. No other abnormality in the lung parenchyma. So this is multiple pulmonary masses with the possibility of central necrosis. Possibility include
It's better to say
metastasis.
cavitation because necrosis may
Okay.
be related to fluid. Okay.
Okay. Yes. So possibility include either metastasis or pneumonia, like
Necrotizing
cavitating pneumonia.
or cavitating pneumonia.
Necrotizing.
Okay. Yes.
So I would do CT of the chest for better evaluation.
Okay. As you said, one of the possibilities is cavitating metastasis. Okay. No extra soft tissue in the neck, no surgical clips of the neck. Just comment on this during description. Okay. Because the clue may be in the neck. Okay.
This is a lung window of the same patient demonstrating cavitating mass in the left upper lung
Okay.
with a thick nodular wall.
Yes.
Most likely,
The
there is
same
no
etiology.
consolidation.
Yes, the same etiology. Okay, or the same differential. If the patient has another CT or, for example, sinusitis and, I think it's a case of Wagner. But from X-ray, just a differential. Okay. Okay, ya boss. This is an easy case. Okay. Proceed.
Right. So there is a mass with the air fluid level in the right upper lung. differential include abscess or septic emboli.
The category,
or
just the category. The category in the last case, multiple cavitary lung lesions. Okay? And now solitary cavitary lung lesion. Give the differential accordingly. Okay?
so either metastasis or abscess or
primary bronchogenic.
right.
Okay. So how to differentiate lung abscess from other neoplastic conditions?
So if the patient presents with fever and increased white blood cell count, then this is septic or infectious. If no fever, then patient maybe need biopsy to confirm the diagnosis of cancer.
Of course, CT first. We comment also on the wall thickness, the uniformity. Okay, is it uniform or irregular or nodular pattern, and also no lung lesions, no surgical clips, and. This is a classic lung abscess. You describe this one too, yeah, boss.
Okay, so this is chest radiograph of adult patient demonstrating opacity in the left lower zone and the right upper zone. There is a scoliosis and the thickening of the right paratracheal stripe. I'm suspecting that there is.
This is a positional. Okay. You comment on this area.
Okay, so there's cavitary. There is a cavitary. Excuse me, I'll just mute someone. Okay, there is a cavitary lesion in the left lower zone with possibility of air fluid level, trace air fluid level, and maybe small pleural effusion. I'm suspecting that there is either an abscess or metastasis in the left lower zone. I would like to.
Please, if solitary, we will put the primary lung cancer before metastasis. Okay, either abscess or cavitating bronchogenic carcinoma. Less likely solitary cavitating metastasis. Okay, so we proceed with CT.
So CT demonstrate a mass with a thick cavitating mass with thick nodular wall and minimal consolidation surrounding it. So this is most likely cavitating bronchogenic cancer.
Yes. In lung abscess, usually there is uniform wall thickness, not nodular. Here it is non-uniform and nodular. Also, we comment on the mediastinal window for lymph nodes and. Okay, boss. Let's continue with you. So, in a solitary cavitating lung mass, this is a classic for lung abscess. It may be a bronchogenic carcinoma. What cell type that cause cavitating lung cancer?
Squamous cell carcinoma.
Squamous cause multiple cavitating metastasis from head and neck and from the lung also cavitating. Okay, can you describe this one?
There is a bilateral central masses with like on the right side there is a crescentic lucency.
Good.
So I'm suspecting that could be a progressive massive fibrosis with cavitation with maybe superadded aspergillosis.
Good. Very good.
I would like to evaluate with high resolution CT.
Okay.
And compare with previous.
Okay. What other etiologies that may predispose aspergilloma infection? You said upper progressive massive fibrosis. What else?
Asperger can in any pre-existing cavity, such
Yes.
as cavitating metastasis or emphysema or nematocele or previous laceration of or pulmonary infarction cavity.
Or TB. Or TB. Okay. Okay. This was mycetoma on top of sarcoid cavity. Sarcoid and TB both are granulomas. Okay. Good, yeah, boss. I think this is a classic easy case. Okay. Just to finish, this is a classic appearance of Aspergilloma. So multiple cavitating lung lesions, usually seen as nodules. If any one of these nodules show central cavitation, deal as all are cavitating lung nodules. If anyone is showing a central cavitation, then all are considered cavitating lung nodules. Cavitating lung nodules may be cavitating metastasis, maybe septic emboli, maybe granulomatosis. So comment on the bones, no bony destruction, no surgical clips. If the patient is sick, you will see a central venous line and endotracheal tube. This most likely septic emboli. Rheumatoid nodules also in the differential. If there is osteoarthritis, or I'm sorry, if there is arthritic changes here as well, but less likely in the list. Okay. Good, yeah, boss. And solitary solitary cavitating lung lesion, maybe lung abscess, maybe primary bronchogenic carcinoma squamous cell type, and also mycetoma cavity will be on the list. But this has a classic pattern. Thank you, yeah, boss. Okay, candidate number 2.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. Okay, deal, yeah, boss.
Presented with a frontal chest radiograph for an adult patient, starting with tubes and lines. I can see there is a porticat with looks good position of its step, and I can see also there is a left humeral arthroplasty. You see there are multiple variable sizes scattered nodules seen in both lungs with no zonal predominance. There is a left-sided pleural effusion. I'm looking at the bone for any bony destructive lesion. So the main differential for these are multiple metastases. Maybe this patient is taking any chemotherapy with this porticats due to could be to primary tumor. Maybe the left arthroplasty related to osteogenic bony tumor, primary osteosarcomas of the left bone, and these are resulting of metastasis with pleural effusion. In my routine practice, I will compare with the previous and look for why this patient have porticats getter if there is any non-primary known.
Very good, yeah, boss. Very good. You have to correlate all findings together. The main abnormality here is pulmonary nodules. Metastasis will be on top of the list. We will add portacas or tunneled venous lines. This may be related to chemotherapy. What about this? I should take history. Maybe a tumor in the like osteosarcoma, or maybe incidental finding due to advanced arthritis or okay. The second case for you, boss. So the main differential or the first
Excuse me, Dr. Ahmed.
Yes.
Do I want to inquire, is the portacath word is used only for the venous access for the cystic fibrosis?
I'm sorry. You can post your question on the chat. Please don't interrupt the candidate or the examiner.
Okay, no problem. Thank you, Dr. Ahmed. Thank you, my friend. Portacase or tunneled venous line. Tunneled venous line. Okay, maybe portacase, maybe Heckman line, maybe Burma cath, whatever. It will be represent a clue in the exam case. In young age, we think in what is the cause? Maybe cystic fibrosis, long-term antibiotic. Also, maybe a sickle cell disease. We comment on the bones, on the spleen, on the surgical clips. So in young age, think of a congenital disorder. In older age group, most likely it is related to chemotherapy. Look at the bones, look for any evidence of metastasis, look for the breast shadow. So this tunneled central venous line will be the clue in your case, most likely. Add other findings to reach the diagnosis. As our friend Candid 2 has a good approach in this case, and the first diagnosis for multiple lung nodules is metastasis. Suppose this is the Candid 2 with me?
Yeah, I'm with you.
Okay, suppose this is another case of multiple lung nodules and the examiner showed you this pattern.
So the lung window demonstrate multiple variable size nodules with central cavitation, as well seen in both lungs and left-sided pleural effusion. I'm looking here for any evidence of there is an endobronchial lesion seen on the right bronchus. I'm not sure.
Definite. Okay.
Okay, so look for the rest of the scan to look for any primary tumor, looking at the bone and in the bone window, and I will look at the mediastinal window for any lymph node.
Good.
These are mostly related to multiple cavitary metastases with malignant pleural effusion. Other differential of this patient is acutely unwell, could be due to septic pulmonary complications, Ebola, and will correlate with the patient's history after reviewing previous images.
Good, yeah, boss, videos. This is also heroin. Okay, they love heroin in Radiopedia. Okay, the last case for you, the same category. Can you comment?
Yeah, so I'm presented with a frontal chest radiograph for an adult patient, and the most striking abnormality is a mass seen in the right mid zone. I don't appreciate its lobulated outline. I don't appreciate any calcification or cavitation in this lesion. I am looking for any other lesions within this. I can see where is the arrow. Yeah, this one, another. But this one had a prominent vessel toward this lesion coming from the high.
Even the lesion itself is not so clear, okay, but the vessels guide us to the lesion, okay.
Yeah, suspecting pulmonary venous malformation, AVM.
Yes, it's called, this sign is called the feeding vessel sign. So again, and here the CT, okay, this is a feeding vessel sign. In a multiple lung nodules, look for a clue. Either the maybe central venous line endotracheal tube. This may be septic emboli. Central or tunneled venous line with lesion in the bone, maybe metastasis or surgical clips. Okay, and also in this case, a feeding vessel sign, maybe the sign of or the clue in this case, like multiple arteriovenous malformations. Okay, in this case, unstable internet. Candidate 2 with me. Do you hear me? Yes. There is some instability in the internet. What about now? Do you hear me now? Okay.
Yes.
Okay. What is the value of mediastinal window in this case? You will ask for mediastinal window because of?
Yeah, so to trace the pulmonary vasculature and also to look for any pulmonary embolism, because these are at risk, and also
And
multiplicity, yeah, liver lesions, liver lesions.
liver, what about the liver?
Usually they have capillary telangiectasia or pulmonary arteriovenous malformation,
Yes,
and these
yes,
patients
yes.
at risk for cerebral AVM also.
Okay, paradoxical, yes. Hereditary hemorrhagic telangiectasia. Very good, يا boss. Thank you, thank you.
Thank you.
Welcome. Okay, next candidate.
Hi, sir.
Oh,
Okay.
with me?
Yes, sir. I can hear you.
Okay, okay. Just comment on this case.
I'm presented with a frontal chest radiograph of an adult patient. At first instance, I can see there's a central venous line in situ with tip appropriately positioned within the cava-vitreal junction. Other than that, there are two large soft tissue density lesions in the left upper and mid zone. There is also obliteration of the cardiophrenic and costophrenic ankles. I'm not able to see the diaphragmatic margins. There is associated volume loss in left hemithorax. So in summary, I'm seeing two large soft tissue density lesions in the left lung. So one of the lesions is having broad base towards the mediastinum in the left upper lobe. And looking at the bones, not able to see any obvious bony metastasis or bony lesions. The right lung appears grossly normal. So in summary, there are two large lobulated soft tissue lesions in the left hemithorax with associated volume loss and mild pleural effusion. So the probable differential diagnosis in this patient could be metastasis. So
what type or what name of this metastasis? What term?
Pleural-based metastasis, maybe?
No, with this size. I mean the size of this metastasis. Canon. Okay. Yes.
So, okay. Cannonball, I thought it was usually bilateral multiple. I'm here only seeing two lesions.
Yes, it's still very large. Still very large. One of the, okay. Any clue about the primary in the film?
Hello?
Yes, I hear you.
I didn't hear you, sir. Can you just repeat what you said?
Okay. Any clue about the primary in the film?
I'm trying to assess the bones now. Clavicles appears normal. Scapula appears grossly normal.
What are the common causes of cannonball metastasis?
Usually renal carcinomas.
So no surgical clips at the upper abdomen. Good.
Yeah.
What else?
Thyroid carcinomas. So I'm
No.
looking at
Okay, no enlarged soft tissue in the neck, no tracheal compression, no surgical, it's just mentioned. Okay, what else?
And GI malignancies.
Okay, and osteosarcoma. Okay, you see this film edge. What is this? Intramedullary nail.
Intramedullary nail, yes.
Yes, was a primary cancer. Okay, it was a case of osteosarcoma, sending this large type metastasis, the right humeral medullary nail with the clue for the primary. Don't forget, in this type of exam, it's called the tricky cases film edge. Film edge. Okay, so you have to look at the edge of the film. Whatever, here maybe surgical eclipse in renal cell carcinoma, or here in osteosarcoma.
Yes, thank you.
Very good, yeah, boss. Very good, yeah, boss. So now again, I have large masses and, oh yes, tunneled venous line also. Tunneled venous line, this is chemotherapy with this type of lesions. Look for the common causes of a cannonball. I know cannonball should be more distributed like this, but very large masses. Renal cell carcinoma, okay, choriocarcinoma. One of the possibilities is osteosarcoma as well. Okay, very good, yeah, boss. I think is the last list of cases. The same candidate. Come with me again. Okay.
Yes. Okay, so
Okay.
I'm presented with a frontal chest radiograph of an adult patient. So at first instance, I can see again there is a tunnel catheter with the tip appropriately positioned within the cavo-atrial junction. At first instance, I can see there is consolidation involving the left mid-zone with air bronchograms, and also I can see metallic clip.
Is
Most
this
likely,
outside the body, a metallic part outside the body? Okay. About this, you think in?
this could be a tunnel catheter, so this could be a chemotherapeutic, or it's single line catheter, so it could be chemotherapy for chemotherapy.
Yes. In such case, a patient undergoing chemotherapy. Okay.
Yes.
What type of lesions that may develop as a patches?
It could be fungal infections or
Yes. Okay. Can you describe here?
I see area of consolidation with the surrounding areas of gangulous opacities in the left the lingular segment of left upper lobe. So there is also some associated smooth interstitial thickening in this region. I would also like to assess the lesion in post-contrast mediastinal window. Other than that, I'm not able to see any other lesions in rest of the lung field.
Okay.
So again, this could be a lesion with significant surrounding lung glass opacification. This could be again fungal pneumonia maybe.
Okay.
Or it could
When a consolidation surrounded by a ground glass,
yes,
the term is
that's what is it?
halo sign. Okay.
Halo sign.
Yes. In a patient under chemotherapy, you think in angio invasive, yes, aspergillosis. So one of the common causes of halo sign density surrounded by ground glass is angioinvasive aspergillosis. We need a history of immune compromise or a chemotherapy like this evidence. So the only clue in this case may be the central venous line, okay, or the tunneled line. This patient underwent a bone transplant, so immune compromised as well. Okay, another case for you, the last case for you, yeah, boss.
Okay.
Name the sign.
Halo sign.
Okay, this patient chest X-ray show multiple nodules. And now, what about the CT?
Okay, so I'm seeing multiple soft tissue density lesions in bilateral lung fields of varying sizes with surrounding ground glass halos. So again, this could again represent fungal infection.
Okay.
Or another DDs could be less slightly
multiple lung nodules. What is the common? Yes.
Yeah.
What type of metastasis cause this pattern?
Hemorrhagic metastasis.
Yes, hemorrhagic metastasis. What are the common metastases that cause hemorrhagic?
Melanoma, choriocarcinoma, renal.
Yes, very good. Hemorrhagic pulmonary metastasis like melanoma, renal cell carcinoma, chorio, or angio, it will cause this type of sign, consolidation, because high density lesion surrounded by hemorrhage. It's a hemorrhagic metastasis. Thank you, ya boss. Thank you. Okay. The next candidate.
Yes, please.
Okay. Proceed, ya boss. 3 months of shortness of
This is a
breath.
frontal chest radiograph of adult patients where I can see there are multiple opacities, which is mainly a rigid peripheral. The largest one is seen pleural based on the right side. I can see there is lucency within
the voice. I can't hear you. Can you hear me, my friends?
disconnection, but I see Dr. Ismail returned. Let's just be patient. He will reshare the screen.
Yes,
I'm sorry, internet also again. Okay.
it's
Okay,
okay. Never
continue,
mind.
boss. No problem.
Yes.
Okay.
So this is an bilateral peripherally, mainly peripherally located opacities. I will put cryptogenic organizing pneumonia and chronic hypersensitivity pneumonia and the chronic eosinophilic pneumonia are included within the differential diagnosis, and also COVID-19 pneumonia could be
Very good.
included. So I'd like to compare with the previous images if it's available and to correlate with the clinical presentation of the patient and proceed for a chest, 3T chest. This is an axial CT chest of the pulmonary window. I can see there is an peripheral consolidative areas with an giving and with an internal lucences giving an reversed halo sign, which is in
Yes.
keeping with an cryptogenic organizing pneumonia, as well as an areas of patchy ground glass opacities. No evidence of an I'd like to check the whole study. It's mainly affecting the upper and mid lung lobes. With the left upper lung lobe is showing an interlobular septal thickening within a ground glass opacification. I'd like to check also the mediastinal window for detecting the mediastinal lymphadenopathy and yes, there is no mediastinal lymphadenopathy, no pleural effusion. Also, I'd like to check the upper abdominal cuts, and also in myotonic plaques, I'd like to check the bone window. So in summary, this is a case of an cryptogenic organizing pneumonia. I'd like to also still the other differential diagnosis included. I'd like to compare with the previous images if it's available, and you can pay my thanks to the referring physician and recommend further follow-up.
Good, yeah, boss. Good, yeah, boss. I think this is a case of eosinophilic. Okay. And this is diagnosed by laboratory test, but the same differential diagnosis is applied. Okay. This is another case because I want to hurry up. Okay. The same consolidation surrounding ground glass. So this is the reversed halo sign. The reversed halo sign, I think this is another one. Has a differential diagnosis, as you said, COOP or eosinophilic pneumonia. Sometimes a lesion like this. Can you comment on this case?
Yes, this is a frontal chest radiograph of adult patients where I can see there is a bilateral peripheral pleural based opacities with
very
an
good.
with the
very
sparing
good.
of the hilar and the parahilar regions.
Just the
Yes,
important point here.
I think this is giving a yes.
Pleural based,
Yes.
not just the peripheral, because in eosinophilic pneumonia
Yes.
or COOP it may be peripheral, but here pleural based. Pleural based, you may think in another differential diagnosis like
COVID-19 pneumonia could be included. And
what if I told you there is calcification here?
Is it an plex due to
yes.
previous asbestos exposure?
Yes.
So
Yes. So patchy opacities, peripherally located, think in COOP or eosinophilic pneumonia. If pleural based with pleural calcification, think of calcified pleural plaques of asbestosis. Okay. If non-resolving, what other differential diagnosis than COOP or eosinophilic pneumonia?
alveolar carcinoma.
Yes. This is one of the possibilities you have to mention also. I think I need to hurry. Okay, can you describe this pattern?
This is a batwing appearance,
Okay.
mainly affecting the central hilar and parahilar with the sparing of the periphery. Batwing appearance that could be an pulmonary edema, pulmonary hemorrhage, pneumocystis pneumonia, and
so we comment one of the important items to comment on the heart. In case of cardiomegaly, pleural effusion, if you can see any artificial valves, it may be a cardiogenic. If the patient has a history of trauma or intracranial hemorrhage, it may be non-cardiogenic. This pattern is a batwing. but the peripheral pattern is called reversed pat
Reversed.
wing. Okay, patches in upper part of the lungs. What is the differential?
Tuberculosis comes on top of my
Yes.
differential diagnosis. Other causes of them, like sarcoidosis, pneumoconiosis, ankylosing spondylitis, neurofibromatosis. So I'd like to correlate with the clinical and to compare with the previous.
And progressive massive fibrosis. The last
Massive fibrosis,
case,
yes.
yes, the last case, unilateral patchy opacities. Any differential?
Also because it's mainly at the upper and the mid lung zone. So tuberculosis also comes on top of my differential diagnosis.
Okay.
And they also compare if it's an yes, it could be an
The
unilateral
patient has
also pulmonary edema or
yes,
pneumonia.
recent noted cardiac murmur and deterioration of the condition. So it may be unilateral pulmonary edema. Unilateral pulmonary edema may be because of positional, maybe acute mitral regurgitation.
Mitral regurgitation.
At Egyptian exams, they love this case, by the way. Okay, because the flow after mitral regurg, it will be directed to the right upper lobe. Okay, so in summary, we have some differential diagnosis according to the patchy opacities. Patchy opacities. If a solitary or multiple patchy opacities in an immune compromised, think of aspergillosis. Okay. If multiple lung nodules or opacities, okay, with this halo type, if nodules, it's hemorrhagic. If patches, I'm sorry, it's also hemorrhagic. If reversed pattern, this reversed halo, think if COPE, think of eosinophilic pneumonia or bronchoalveolar carcinoma. From X-ray, you may be deceived and say it's peripheral patchy opacities, reversed patwing, but you may encounter calcified plaques. So remember, asbestosis may give this pattern. Okay. And the patwing pattern, patchy opacities, pericardiac with cardiomegaly, maybe pulmonary edema, cardiogenic, normal heart, trauma, intracerebral hemorrhage, non-cardiogenic, and apical patchy opacities with volume loss, maybe tuberculous, maybe progressive massive fibrosis, unilateral, maybe pneumonic, maybe unilateral pulmonary edema. Okay, thank you, and see you inshallah next time. Assalamu alaikum.